Wonderful.
Hi, everyone. Sorry about being late. Just had a few IT issues. Thank you for joining us for this tutorial. So the first one, this is a psychiatry tutorial on personality disorders. This is part 1. We'll have the part 2 on Wednesday, and it's given to us by Dr. Tom Dalton. Just a few rules. If you're watching via Zoom, any questions or comments that are covered in the moment, if you just want to pop it into the chat, and any question that can wait to the end, if you just want to pop it into the Q&A. If you're watching the Facebook Live, just comment your questions in your comments and I'll pass them on to Tom. And that's all from me now, and I'll pass over to Tom. Thank you.
Wicked, thank you very much. We were just having a few sound issues. Could someone just drop in the chat if you can hear me okay? I have a raised hand. Is that a raised hand of... You can hear it? Okay, good. Just wanted to check. How apt that in this most difficult of topics, we're having disordered sound. Okay. So yeah, tonight's talk is on personality disorders, which is one of my favorite topics to teach on, mainly because it's quite a challenge to really make sense of it. But I won't get ahead of myself. This is just a little disclaimer from becoming a doctor, just saying this is all my stuff rather than theirs. So email me directly if you have any complaints. And this is what we'll be covering in the lecture. So as a part 1 today, we're mainly going to focus on what personality disorder is, just how to even understand this whole area, and also the etiology of personality disorder, which I think is really, is central to the question of kind of what it is and how to understand it and how to approach it. So hopefully things will start to make a bit more sense by the end of this part 1 evening. Part 2 on Wednesday, we're going to go into a tiny bit more detail on a couple of really interesting things that generally you only tend to even start learning about if you start doing psych training. So hopefully I can share a few little interesting, won't spend ages on it, but it's a few bits of theory which are quite valuable if you can get your head around them in terms of making sense of a whole lot of stuff, particularly related to personality disorder, but related to other things as well. And then we'll also look at a lot of different other types of personality disorder. So tonight we're going to actually focus on only one type, which is the one that you will see most often and the one that I think is most important. So part 2 on Wednesday, we'll look at all of the other types in a bit less detail, but for med school exams and things, you do need to be aware of all the other types, and it's quite easy sort of MCQ fodder. And then we'll think about the management as well. So that's the plan. But to start with, I don't quite know, to be honest, like what stages you guys are at in med school. So it would be, so I don't know if you have any understanding of this topic at all, or if you've kind of encountered it a bit, but maybe haven't had much specific teaching on it. But if a few people would be happy to drop into the chat, just your understanding of what personality disorder is, any definition. Absolutely no wrong answers at this point, because often I think this is quite badly taught. So if you know anything, this is a talk for medical school students, but oh, cool. People in year 12 even, wow. Okay, that's extra keen. No worries. Yeah, no, don't worry about that. I mean, it's fine. This is a topic that, to be honest, often isn't really much taught in the whole of med school anyway, but it's a useful one to start getting awareness of. But yeah, no, don't worry at all. But if anyone has encountered this concept before of personality disorder, what it might be, any theories or, brief definitions perhaps at a guess, or what comes to mind? Presented a diagnosis of exclusion in psychiatry. No, I mean, that's a fair point. That is how it's often viewed. The 3 main broad types, I'm guessing you're thinking of the sort of type A, type B, type C classification. Excellent. And then just about like, what actually is this that we're talking about here? I think it's easier perhaps to define it in negative terms of what it's not. Diagnosis of exclusion. No, that's fine. I mean, another question for you quickly. Are there any, if you've never encountered this before at all, I think this is quite a good question. What just hits you when you think of the whole concept, the name, the label of personality disorder, are there any, or perhaps you've learned a bit about it and you've encountered some of the kind of controversies, I suppose, with this whole label? Anyone? Yeah. So we've got bipolar disorder. Is that what it means? It's certainly, you're not wrong in a sense, in that certainly sometimes people are misdiagnosed as having bipolar disorder when actually have their type of personality disorder, or people can have both. So I mainly think of borderline personality disorder, which affects people's relationships with others. Absolutely. And you're right on the money in terms of what we're going to focus on this evening. People who struggle to maintain social relations, interact socially, often provoke strong reactions from others. All good stuff. Okay. So I'm getting a sense there's quite a mix of levels of understanding of it, which is good. Okay. Well, the first thing I guess I'd like to say about personality disorder, which hopefully we've maybe started to pick up on vaguely, is that it is a conceptual minefield. It's really problematic in a whole bunch of different ways, which I think probably, I would hope maybe, struck you just from the name of it. Like, firstly, what is this, what is personality? Does anyone really know what that is to start with? How can that be a disorder? Personality, and then if it is, who gets to decide what's disordered, what's not? Is this really relevant to medicine? It seems like a bit of a backwater of psychiatry, and then it hits on a whole lot of even more difficult questions about the nature of people, and it's very confusing, and I want to be upfront, I suppose, about the controversies that exist within this area, and I hope we can have a good discussion about this as we go along, but yeah, it's a tricky area, and I think we should be clear about that. And I often say, if you feel like you're completely happy with personality disorder, it all makes sense and it all sits comfortably with you, you probably haven't understood it well enough, because actually there are some things in there which maybe shouldn't sit too comfortably with us in terms of the way we use this label. But yeah, let's bear this in mind going forward. But hopefully by the end of this pair of talks, we should make a bit more sense of it and have a sense of what this is and how to not immediately fall into the kind of intellectual traps that exist. So I'll start with talking about why this is important. As I said, people have said, you get brief teaching on it at med school, something about different types. So it all sounds a bit pseudoscience, pop psychology kind of thing. But why is this important for medicine and for anyone who wants to become a doctor? Well, firstly, these disorders are fairly common. So I mean, that's a good enough reason. And they are disproportionately represented in healthcare settings, particularly the one we're going to talk about tonight. So this is something you will see a lot of as a doctor, and you'll see a lot more of it than is actually representative of the general population. And also, this is a group of patients who often have quite a high consumption of healthcare resources for various interesting reasons that hopefully we'll try and touch on and talk about. This whole area, you run into some tricky problems with management, and that's in terms of what you do about the various diagnostic quandaries that can come up sometimes. Sorry, I'm being quite vague in all of this. We'll put more detail to this a bit later on, but what you can do in terms of medical terms, but also management issues in terms of perhaps behavior and just people management, and how we help someone get along on a ward. So there are all sorts of problems that come up, I guess. And also, I think it's really important to spend a bit of time, so I've got 2 sessions, to really get your head around personality disorder for all of the above reasons, but also because it's an exceptionally difficult topic to make sense of, which I think all of you, including people who haven't even got to med school yet, can make some sense of it. It just requires a little bit of thought and patience. But another really big reason, possibly the biggest reason why it's important to have teaching on personality disorder, is the issue of stigma. I mean, we know stigma is a problem in mental health generally. All sorts of different mental illnesses are stigmatized in different ways in the general population, but personality disorder is specifically, most people in the general population haven't really heard of it, but personality disorder is heavily stigmatized by healthcare professionals. Among patients, it's the ones with personality disorder that are stigmatized, by doctors, by nurses. And that's a real issue. I mean, obviously it's wrong apart from anything, and it's a shame that that's the case and it causes suffering, but also it leads to less than optimal management of these patients. People don't get the right care. And this leads to more problems, which kind of increases the stigma because these are seen as patients who are problematic, patients who are giving me issues, you know, heart sink patients, sometimes you might say, these sorts of things. And it just feeds back into the stigma and makes the whole thing worse. So I'm really glad that I can hopefully deliver some good enough teaching to people right at the start of their medical career, so that you don't rush in there with all of these stigmatizing assumptions that people often have and get just drawn into it as you go into the rest of the medical world, where many people still hold on to the stigma a lot. But in terms of what personality disorder is, well, this is essentially the definition of it, the textbook definition, if you like. And it's, you know, I mean, you can all read, but we're talking about this relates to someone's internal experience, so their thoughts, their emotions, and also their behavior. And it's something, whatever it is, it deviates markedly from what's normal or the expectations of you know, the normal society around you. And it's quite pervasive and inflexible. So this is something that affects lots of areas of someone's life, and it tends to remain kind of stable over time. And typically has its onset in adolescence, which we'll talk about, and causes distress or impairment. Obviously, that's part of the definition of any kind of illness or disorder, you know, otherwise it wouldn't be a problem. But I think these words maybe don't add much to, if you start with, if we're not really sure what we're even talking about here. I mean, in one way, you can define it as a personality that is sufficiently different from normal to cause problems. You know, and that's not an unproblematic assertion to make, but that's one way of perhaps defining it, that hits at some of the problems with it. Like, again, who gets to decide what is the right personality to have and what's the wrong personality to have? These are all things that people think, and hopefully we can get away from those kind of ideas, perhaps. But yeah, as I said, it was fairly common. It's about 5% of the population. So like, that's quite common. You know, in terms of all the illnesses you'll learn about in med school, this is a pretty common one. So it's worth knowing about, basically. Right, I'll start with a case, get us in the game. So this is a lady I saw recently in emergency department. She came in with an overdose of 300 milligrams of fluoxetine. Does anyone know what an approximate normal dose of fluoxetine might be that someone might be prescribed to take every day? Have a rough guess. I'm just looking for a ballpark. 30, great, perfect. So 20 is the starting dose, 60 is the maximum dose. Absolutely right. Sorry, people said, someone has actually specifically said that. I was only reading the last bottom answer, but yeah, you're all correct. So 300 milligrams is not a mass, it's kind of 5 of the maximum daily dose. So this isn't a very big overdose, is the first thing I'd say, which raises all sorts of interesting questions, because you might assume people attempt to end their lives, very sadly, and that's the intent, and they try to do it somehow, and there we go. And hopefully they survive and receive treatment and receive help and don't want to do it anymore. But there are lots of different reasons why people might take an overdose and try to harm themselves that aren't just limited to trying to end their life. And maybe this case starts to look a bit like that, because it's not a particularly, it would be surprising if the person genuinely believed that just 5 of their tablets that they normally have 1 of in a day would kill them. So a few questions coming up, perhaps. And then we also have this non-suicidal self-injury, as is, I think, the most useful term I've found. This is the self-harm that we're all probably a bit familiar with in terms of cutting yourself. Again, manifold reasons why people do that. And I don't want you to see this and think personality disorder, because that's not really accurate. People with all sorts of different diagnoses and different problems and different causes of suffering engage in non-suicidal self-injury. There's a bit of an association between personality disorder and self-injury, which we'll talk about, but it's, yeah, well, we'll talk about it, but don't just immediately assume. Anyhow, and then we've got this, we've picked it up on this already a little bit, relationship problems. And particularly this person felt overwhelmed with anxiety and anger as a result of this sort of trust up that they had with their boyfriend. So there's not much to go on there, but let's look at the mental state for this individual. So they are emotionally labile during the assessment. They weren't consistently kind of low in mood in a very obvious way, which sometimes people are if they have really bad depression. So that's one feature. But they feel low in mood all the time, and they particularly describe this as feeling empty. And they also talk about a voice in their head, which tells her to harm people and that she's worthless. And long-standing suicidality. So this is not just a one-off, in fact. This is something that has been troubling her for a long time. It's a repeated pattern of perhaps it's a response to overwhelming states of distress. And then let's think about the background. So you see this person in A&E who's come in with self-harm, and you take a full psychosocial assessment, and you find out abuse in childhood from a close family member. I mean, we'll go into more detail about just the kind of effects that that might have, but you can, maybe you can't, I don't think I can really imagine the impact that that could have on a young person. And then there are on this kind of ricocheting through this person's life, ongoing difficult relationships with their immediate family, and also rows with kind of their employers, stuff like that. And they have a diagnosis of anxiety and depression, but not really made much improvement so far. And they also frequently attend their GP. We've started to hit on maybe overusage of healthcare resources, and with abdominal pain. And then also, as I said, this is a pattern. So several previous overdoses. Right. I'm going to open the poll. So you should all hopefully be able to vote in the poll for the first knowledge check slide. Good, someone is voting. Okay, you're able to do it. What is the diagnosis here? And again, this is a tricky topic. I'm not expecting you all to get it right, or even half of you to get it right. So have a punt, please. I can see 7 of the 20 people have voted. So please just, and obviously I don't know who's voted for what, but I'm just interested to see the spread of answers. So I'll give you 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Perfect. Oh, nearly everyone. Right, I'm going to end the poll now. Okay, so these are the results we have. Now, I'll be quite honest, this was a trick question. There are multiple correct answers, so sorry for being a dick. But actually, you have all collectively got all the right ones. The only one that really doesn't look very likely in this situation, although you wouldn't have been completely wrong for voting for it, would be psychosis. So she does have a hallucination, but that on its own, without any other features of psychosis, and in the context of all of the rest of the stuff, that would be probably low down your list of differentials. But the most popular one is borderline personality disorder, followed by emotionally unstable personality disorder. And in fact, these, well, they're not quite synonyms. So the current label that we use for this diagnostic construct is emotionally unstable personality disorder. It used to be called borderline personality disorder. So in that sense, they're one and the same. But actually, we now understand we've subdivided emotionally unstable personality disorder into a borderline type and an impulsive type. I wouldn't worry too much about all those definitions, but basically, yeah, they're more or less the same thing for your purposes now. Technically, if you go really deep down the psychiatry rabbit hole, they're slightly different, or at least borderline is a subtype of emotionally unstable. Anyhow, and then 5 of you have gone for depression, and you're absolutely not wrong. I mean, she has a diagnosis of depression. She's feeling really low. She feels suicidal, and she's attempted to harm herself. I mean, that gives you certainly a good enough bunch of symptoms of depression to go on. And 3 people have voted, which I'm glad of, for complex PTSD, which is quite a new diagnostic idea on the block. And in some ways, although not completely, it is an attempt to give a better label, and not just a label, but a better kind of whole approach and understanding of emotionally unstable personality disorder in some ways. I mean, they're not the same thing. If you look at the sort of symptoms criteria for complex PTSD, they don't entirely overlap with those of emotionally unstable personality disorder. But I think approaching, EUPD, as it's called, as a complex PTSD is probably a better way to go about it often than just seeing it as a personality disorder. Anyway, this will all start to make more sense, I hope, as we look more at the etiology of personality disorder. But great, you're all getting on the right page. And if none of this is making any sense, particularly if you're early on in med school, don't worry. I guess what I'd say is, yeah, there are sometimes confusions between different mental health diagnoses, and the personality disorder is maybe blurred into some of them. And that's fair, because people can have both. They can have emotionally unstable personality disorder, and they can also have a diagnosis of depression, anxiety, bipolar disorder, whatever it may be. They can have psychosis, they can have kind of any other mental illness. The personality disorder, as I hope we'll see, is maybe something that kind of might underlie some of those acute syndromes. So, I mean, depression, anxiety, whatever it may be, often they have it, they're episodic, or there's a time when the person wasn't experiencing those symptoms, and then they develop the illness, and then maybe it gets treated and it goes away. Whereas personality disorder is a bit more stable over time, kind of there since early in life. Not completely, but in quite general terms, it tends to be more like that. So it's a bit analogous to, I don't know, having a congenital cardiac malformation and then having sort of heart failure or ischemic heart disease on top of that kind of thing. And they are related, very much so, but one was there and is kind of always going to be there, and the other is sort of super added on top and then might go away again. But personality disorder is not as permanent as a congenital cardiac abnormality. It's quite a loose analogy. Anyway, let's go on and try and continue making sense of this. Sorry, that was just that. Right, so let's start from the beginning and try and work, what are we talking about when we even talk about personality? And that's a good way to start, I think, before we get on to like how it can be disordered. So, I mean, this is what we understand personality to be, the things that make a person a person. I mean, you don't really need to be told that. I suppose one way of saying it, it's sort of the visible aspects of the way your brain works. Like personality, it's not really located, it's not a subset of the brain, the mind, whatever. It's kind of a product of the whole way your brain works that's different to the next person's brain. But obviously, there are lots and lots of processes that are completely under the radar, that are not conscious, that are, you can't really observe them in terms of behavior, or the person can't observe them subjectively. So personality is maybe the visible parts of that. And I guess you have to slightly shelve a lot of our cultural ideas about the soul and what makes a person a person. I'm not going to rubbish all of those ideas, but I guess put them to one side for the time being, and I'll approach it from a purely sort of neuropsychiatric thing for tonight. Personality is basically 50% genetic and 50% environmental. Bit of a sweeping statement. It's more that if you measure any specific personality traits, which you can do with specific psychological tests like impulsivity or impaired set shifting or whatever, generally there's about a roughly 50% genetic loading, and the rest is environmental. The genetics of it is not very, I think, not really very helpful in terms of explaining how personality disorder comes about. So I'm kind of going to leave it for today. There's not a great deal to add there, but in terms of the environmental bit, I'm going to focus on that. And the environmental influences that are important are attachment in infancy, and I'll talk about what that means. But, we're talking about the family environment, your social environment. This is the environment that we mean, your earliest relationships and all the people you kind of interact with over the earlier part of your life. This is the sort of developmental environment. Environment can include lots of things in terms of air pollution or whatever, but that's what we're talking about in terms of personality, particularly if there was any kind of traumatic events there, which can have a big impact. But let's think about attachment. I think if anyone has encountered attachment theory before, perhaps you've done it a bit in med school, you might remember something about some geese, you might remember something about wire monkeys, I don't know. That's all I remembered from med school, thinking back on it. But these things are kind of relevant to the development of the theory, but I'm not going to talk about them tonight. I would encourage you to think of attachment as actually much more important than you might imagine. It's a bit like, it's the foundation for so much in psychiatry. It underlies a lot of different concepts, illnesses, whatever, syndromes within psychiatry, and in fact within a lot of medicine. It's a bit of a foundation for lots of stuff that we understand on a more superficial level. In fact, it's kind of the bedrock of psychiatry in some ways, I like to think, but maybe that's a bit grandiose, I don't know. But let's think about what attachment means, and I'll start with a question. What can a baby do? Don't worry about trying to answer that question, because I'll tell you the answer. A baby cannot do anything. I mean that in survival terms, I guess. Babies can do some things, but in terms of survival, a baby's ability to exist independently, it literally has no life skills. A baby is completely, and I mean, this is obvious, but it's a really important point to bring to mind at this point. A baby has no ability to survive independently. It is entirely reliant on its primary caregiver. I'll refer to that as the mother. It's typically the mother. Obviously, it can be the father. It can be whoever is looking after the baby the most. Baby cannot do anything. Completely dependent on the primary caregiver. A famous attachment researcher sort of in the last century famously said, this is Bion, if anyone's heard of him, there's no such thing as a baby. Because there isn't, because a baby on its own cannot exist. It will cease existing quite quickly. The only thing that exists is the dyad of the baby and the caregiver. So there's no such thing as a baby kind of on its own, is what he meant. And there's interesting sort of things you can talk about in terms of why this happened, which I'll just look at briefly in about 10 seconds. Obviously, survival pressures favor a larger brain. That's allowed us to do all sorts of things and conferred a survival advantage on the human race. But also, being bipedal confers a survival advantage because it's slightly more efficient to move around. But of course, being bipedal entails having a slightly narrower pelvis than our quadrupedal colleagues in the animal world. And then you run into a bit of a sort of toss-up between these two things, because clearly you have the birth canal and the head can only be so big and the birth canal has to be a certain size. So you have a bit of a tension between those things. And the solution that evolution has given us is basically that humans are born humongously premature. We're nothing like the sea turtles that can, be born and without any caregiver at all. They have to fend off seagulls and survive and somehow make it to the ocean. Human babies are completely dependent on another human, several other humans, for, well, kind of 18 years, but at least absolutely for a good few years to start with. And they absolutely cannot exist without them. So, I mean, maybe these things are why that's happened. But in terms of the result of this, a whole load of really interesting stuff starts coming into the mix because of this dependent relationship. And it's often thought of perhaps as like the whole reason humans have developed the kind of complex language and thought and self-awareness that we have is because all of us now, just because of evolution, start off our lives in this relationship where we're completely dependent and communicating constantly with another human. And there's a sort of reflexivity in that is more than just if we were just on our own the whole time. So anyway, very, very interesting, but I'll ignore that for the time being. In answer to the question, what can a baby do? We know a baby can cry. That's the kind of main thing a baby does. And obviously, what's the function of that? It's to get the attention of the mother. Now, what happens in this process when the baby gets the attention of the mother? I'm going to load up this video at the end, I think, and leave it for the time being. Or perhaps I'll show it at the beginning of the next. Yeah, I'll show it on Wednesday because I think it's a useful one. It's a video illustrating how much goes on between a mother and a baby under normal circumstances. So yeah, mother and a baby, if they're, the baby's not asleep, they're kind of constantly interacting. And yeah, say imagine like an 8-month-old baby. The baby like looks at the mother, the baby smiles at the mother, the baby makes sounds, and the mother's constantly interacting back and forth, imitating the sounds, kind of smiling back at the baby, all of this sort of stuff. And if you look at it, if you kind of watch that process, as people have studied it in a lot of detail and like sort of coded it and done all sorts of things, it's incredibly sophisticated. So this is a child before they can talk at all, before they have any ability to survive independently. They have no language whatsoever, but there's so much going on in the interaction between a mum and a baby. There's masses of communication happening, and you kind of gives you a flavor actually how much is going on there, and how much must be happening in the baby's brain, I guess. That's not just being fed and therefore surviving until they're old enough to feed themselves. And I want to focus a little bit on that now. So the attachment relationship, this is the relationship between the baby and the mother. It's kind of one of the important parts of it is the repeated cycle, which I'll talk through now. So baby, this is a pictorial representation of the baby's mental state. Babies obviously have all sorts of problems in terms of, I don't know, they're hungry or they have cramp or whatever it may be, and they cry. Now, a baby has no ability to think at all. It can just feel that distress. That's all a baby is able to do. And all it can do with that is to throw it out there. I'm distressed, and cry about it. The baby isn't able to think its way out of that problem. I mean, it's not actually able to do anything about the problem, but also it is not able to even conceptualize what the problem is. What does the mother do? Well, the mother comes in and does actually a whole host of things beyond just solving the problem. The mother recognizes that the baby is sad to start with, and that's quite important. It's not just that the mother's clocked it and there's going to do something about it. The mother comes in and goes, oh no, poor baby, you're sad. And the baby sees that its distress has been seen. But not that its distress is shared in the same, like the mother doesn't become overwhelmed and distressed and can't cope, hopefully normally. The emotion is there and is sort of seen and named, whatever. I mean, in various different ways, just sort of at an emotional level, as well as later in life actually being physically named. But it's not, the mother doesn't get overwhelmed by it. The mother can sort of cope with it and convey this back to the baby. You know, this problem feels like it's completely overwhelming you, and it's, you know, you can't do anything about it. And to be fair, if the mother wasn't there, this would be the end of the world. Like, the baby doesn't get fed, baby dies. So the mother, you know, is able to contain that world-ending distress, and no, it's not the end of the world, it's going to be okay. And this cycle repeats and repeats and repeats and repeats. This is what we call in psychiatry containment, which is a word you might encounter. You might have encountered already, but you certainly will encounter if you do anything in psychiatry. And it sort of means what it says, I guess, that the distress is sort of wrapped around, it's cared, like it's okay, you know, I don't know, all of these things that I've just said, that's what containment means. Now, obviously this is how the baby gets looked after, so fine, but it's so much more than that, because as the baby, this happens many, many times a day, day after day after day after day. Gradually the baby internalizes more and more capacity to think, and it, as far as we know, it sort of does this through the thought, the emotion being fed out to the mother passes it back, and there's a sense of, between themselves, they make sense of it, and the baby gradually takes on more and more of those abilities, and, you know, obviously learns to speak and by copying, and then is able to develop more and more sophisticated ways of conceptualizing its own internal world, its thought processes, naming, oh, I feel sad now, I feel happy now, whatever. And gradually, as an adult, where, you know, obviously we still feel distressed the same as we did when we were a baby, but we are able to contain that distress ourselves, basically through repeated experience of the mother doing all of those things, reassuring us, naming the distress, recognizing the stress, but the distress is okay, it's not going to overwhelm you, it's going to be fine. We become able to do that. We learn how to do that by copying it. However, if you have a disrupted attachment relationship where this process is not happening quite as it should, and it can go wrong in all sorts of different ways, but essentially you end up with someone who, although they learn to speak, they learn to dress themselves, they learn to do all the stuff that, you know, on the surface you do as an adult, but actually something is missing in their ability to contain their own emotion. This world-ending distress that comes upon the baby, and the baby is unable to think its way out of that distress, kind of, that inability remains to some extent. Something bad happens and the person is unable to, they just feel completely overwhelmed by that distress, and they're unable to kind of think their way out of it, name it, take a step back, take a deep breath, whatever, all those stuff that we do as adults to manage our anxiety. Or, you know, maybe they're not totally unable to do that, but there's a threshold, you know, I mean, anyone, if they're extremely, extremely distressed, is going to feel overwhelmed, but that threshold is lowered, perhaps, if this containment has not gone in place. So, what does this all have to do with personality disorder? Well, hopefully we'll make sense of that. I want to think a bit now about the etiology of personality disorder, because hopefully you've started to see in what I just explained, how much is going on as a baby, and if that goes wrong, maybe you end up with these sort of states of overwhelming distress. And you see a bit echoes of that from the case that we saw at the beginning. They've had a relationship breakup, you know, quite distressing for anyone, but they've been completely overwhelmed, unable to kind of cope with it in what you might call a normal way, and have ended up wanting to end their life. Like, that's serious stuff. Hopefully have a bit of a flavor of why that happens. But let's lay it out in a nice colorful flow diagram, which I enjoy. So good enough attachment relationships. This is what anyone might refer to as a grossly normal childhood. And this is the phrase that is actually used in attachment theory, because no parent is perfect and no parent has to be perfect. You just have to meet a basic standard of responding to your baby's needs. And this will lead to, I guess, what you call a normal personality. What do we actually mean by that in this particular case? Well, you have mostly normal ways of meeting your own basic psychological needs, because we all need stuff. We need to interact with other people. We need validation from other people. Everyone needs that. Everyone basically needs love, if you want to put it in those terms. And we have normal ways of getting that in terms of forming relationships, blah, blah, blah. And also, we have actually quite a flexible, different, repertoire of ways of responding to situations. Particularly maybe stress. There are lots of different ways that an individual can respond to stress, and they can kind of choose how to respond to it in a sense. But on the other side, if you have disrupted attachment, or particularly if you have developmental trauma, now there is a really big overlap between abuse in childhood and what later becomes personality disorder. It's a huge overlap. I mean, I'm not saying everyone who's abused develops personality disorder. Not everyone who has a personality disorder has obvious overt abuse, but the overlap is there. This leads to specific adaptive responses, and this is the best way. If you take home one thing from this talk, think of personality disorder as that baby brain or that child's brain just trying to adapt as best it could to the environment it was in. This is why environment is so central to it, because every brain just does the best it can in its situation to survive. It does what it has to do to get through that, to survive in that environment. And then unfortunately, obviously, you get out into the, short-term survival. Great, the baby survives and gets through and has its needs met in whatever that may be. But the adult world and society isn't actually like that earlier attachment, that disrupted attachment, abusive attachment relationship that was there. So it leads to problems, dysfunctional ways to meet basic psychological needs, and inflexible patterns of interaction. You have a more limited repertoire of ways to cope with stress. You kind of fall back on some quite kind of primitive, you might say, ways, because you haven't been able to develop the full range of ways that people can cope with stuff, particularly distress. So this is hitting a bit closer to what personality disorder actually is, I hope. Now let's think a bit about developmental trauma. And this is quite interesting. There's a bit of neurobiology, which I'm sure you're all enjoying after all this waffly psychological shit. I'm joking. I love it. But in terms of the effects that trauma has on the brain, and this is, being abused as a child, it affects basically the threat response circuit. So the HPA axis that we all know and love, this is your physiological response to stress. Developmental trauma has a big impact on that, as it would. So you're trying to adapt to an environment that is quite hostile and threatening, or much more hostile and threatening than the normal environment that people in today's society usually grow up in. So you end up with adaptations that result in differences from that normal society, and we have the normal, abnormal personality. But in terms of the specific parts of the brain this affects, we're talking about the limbic system here, because this is your threat response circuit at the end of the day. It's also where all of your emotions are, really, but we've got the amygdala, obviously the center of the brain, the center of fear in the brain. And it's all quite complicated in terms of which bits of the brain, which bits of the limbic system, whatever, get affected at different ages where the trauma occurs. And often there's a bit of a latent period where nothing really happens. And then nine-ish years later, according to the stats, you start to develop symptoms and problems, which you could talk about for ages, but I won't have time. But I want to just think about one little bit of the brain. If anyone knows what the uncinate fasciculus, or can guess what it does, you will have a million cool points, but I didn't know what it was as a med student, so I won't quiz you on that. But if you look at what it is connecting, this is the orbitofrontal cortex, so the frontal lobe kind of behind your eye. It's connecting that to the medial temporal lobe. So the medial temporal lobe is where the amygdala sits. The orbitofrontal cortex, so the frontal cortex is thinking. This is cognition. And yeah, hopefully you're maybe vaguely familiar with that idea. That's what the frontal lobes of the brain do. But the orbitofrontal cortex is thinking about emotion. It's the part of the brain that is, broadly speaking, most in charge of that, even though it's all a bit distributed across the whole brain, whatever. So you have this connection between the orbitofrontal cortex and the medial temporal lobe. Now, if someone has experienced trauma during their development, child abuse, essentially, or many different kinds of trauma, this tract is actually smaller, like it underdevelops. And There may be various reasons why that happens exactly, but the result is, I guess, what you see in emotionally unstable personality disorder, for instance, that you're less able to think your way out of your distress. Something bad happens and you feel very, very overwhelmed by distress, by anger, anxiety, whatever it may be. And you can't, or you're less able to say to yourself, no, it's going to be okay, take a deep breath, this isn't that big a deal, I can get through it. All those things that I guess we normally think our way through when we're distressed. This white matter tract is smaller, and there's a real like neurobiological correlate of the observed lessened ability to think your way out of distress. So that's just an interesting thing for you there. Another interesting question. So I'm going to open the next poll now. And while I do, how do I? Okay, right. I'm launching the next poll. Each of these colored bars, so these are a collection of symptoms, and they're not personality disorder symptoms per se, but they are dysfunctional ways of processing distress, or they can be thought of as such. And all of these bars are a type of abuse. Now, the blue one, you can see is kind of, well, for 3 out of the 4 is the biggest. This is the biggest impact. So this is the proportional impact of this type of abuse on this symptom. So basically what we're saying is the blue one seems to be most important. Can anyone guess? Well, can anyone please all guess? And I'll give you 10 more seconds. Only 5 have voted now, but just chuck in a guess again. I'm not expecting you to get this right. 7, 6, 5, 4, 3, 2, 1. Marvelous. Right. Oh, last few votes coming in. Great. So the majority have gone for neglect, and you're absolutely on the money. And this is something that I think surprises us, that neglect is quite this damaging. Hopefully it maybe makes a bit of sense actually in terms of what we've talked about already, in terms of, you know, that response to the baby, the attachment relationship, all of that, and what can go wrong if that doesn't happen. Neglect is the absence, or at least partial absence, of that. And because you'd think, I suppose, that kind of active, if you like, forms of abuse would be more harmful. And I mean, don't get me wrong, they're extremely harmful, like you can see from this graph. But actually, I think maybe we might be inclined to underestimate how harmful neglect is. And also, you know, the Venn diagram that I just showed you on the previous page, abuse and personality disorder, that crescent of people who don't appear to have experienced any childhood abuse. Neglect is a bit harder to pinpoint. Particularly emotional neglect, which is really what we're talking about here. Obviously, if a child is seriously neglected in terms of their health and their needs, basic needs, often will get picked up by social services. But emotional neglect, a kind of lack of responsivity to the baby's distress, very like, how would you really know if that was there? And if it was happening to you, would you know that that isn't normal? So it's a much more tricky one to pick up. And I guess I'd put it to you that, you know, and I mean, I don't know exactly what accounts for that crescent, that the people who've developed a personality disorder and don't appear to have had any kind of abuse whatsoever in their life. But if you see a big crater in the ground, you think something has caused that crater, hasn't it? Like, big craters in the ground don't just randomly occur for no reason. And it's, I guess you can say the same about personality disorder. If someone's, you know, ability to interact and I don't know, various things that we'll talk about when we go through the different types of personality disorder, but to think, to feel, all of these things, if something's gone wrong there, like, it doesn't just randomly happen for no reason. Like, yeah, there's a 50% genetic component, fine, so that's part of it, but there must be something that has caused that to happen. You can kind of just say that almost from first principles, because the brain adapts to its environment, and if the brain has adapted in some funny ways, the environment must have been problematic in some way. I think that's a useful idea to hold on to, because one of the big components of the stigma around personality disorder is sort of kind of blaming people for being ill, really, is how it's often, what's kind of underneath the surface sometimes, and it's just not accurate. And just another little bit of neurobiology for you. So this is taken from the studies of Romanian orphanages, and this is kind of the most extreme examples of neglect that have ever been studied extensively. There are a lot of quite harrowing documentaries about them. But basically, this is a brain scan of 3-year-old children. The whole brain is smaller. The ventricles are larger. The skull itself is smaller. The whole brain is underdeveloped due to that extreme neglect. Like, this has an absolutely visible impact on the brain development, quite apart from all of the psychological stuff that we've talked about. I mean, they're two sides of the same coin. I want to hammer that home. But just if it makes it easier to understand, to physically see it. And, you know, clearly this is very, very, very extreme, and you're unlikely, I hope, to ever see anyone who's experienced that kind of neglect. But, you know, that's just to make it more obvious on the scan. Right, on we go. So we've done that. Good. Let's think for the last 10 minutes or so about emotionally unstable personality disorder in particular. And that's obviously the one that we've kind of been talking about most of the way along here. It's also the one that is most prevalent, that you will see a lot of in healthcare. It's not actually the most common personality disorder. We'll talk about that on Wednesday. But it's the one that you're going to see the most of. It's going to cause you the most problems, if you like, as a doctor. And that's why it's really worth making sense of it. And obviously, emotionally unstable, that's kind of the big feature of it that's in the name. And hopefully that is starting to make sense now for you in light of attachment theory, in light of what maybe has happened or not happened in the attachment relationship. And particularly something that can kind of be thought to lead to personality disorder, to this type of personality disorder, is maybe attachment relationships that have been inconsistent. Maybe sometimes the parent's there and sometimes the parent's not there, or that's true, but in a kind of emotional sense, like sometimes the parent is very, very preoccupied, and even though they're physically there, they're kind of not emotionally there, if you like. And that sometimes on, sometimes off pattern, and this is observed in, like, you can observe this in 2-year-old children in special experimental studies that are set up to study attachment types. You see, basically, they turn up their attachment signal volume to maximum. So, and this means, you know, if the parent is going away or whatever, or is about to leave the room, or even is just there but is not paying them attention, they're really, really distressed and they're clinging to their parent. If the parent is leaving, they're crying, and if their parent's gone out of the room, they're inconsolably upset. And so the purpose of that, like in practical, like evolutionary survival terms, if the parent's sometimes there and sometimes not there, you can increase the chances that they will be there by turning up your attachment signals to maximum volume. You know, if the parent's quite preoccupied or whatever, or is not in the house, or if you cry really loudly, they might come back and look after you. So there's a reason why that happens, but it's not just how the child behaves, it's how the child feels. Like, it's not like, and they're kind of one and the same coin. Like, this is why it's called emotion. It's about our motivation to do stuff. So you end up with an adaptation to that environment that means you feel more distressed if maybe you perceive attachment relationships becoming awry. And of course, that kind of a process of attachment doesn't end when you leave home. We're constantly forming attachments with other people. And something that is, I've got ahead of myself. Something that is very, very common in emotionally unstable personality disorder is kind of unstable relationships where if the person perceives that if the patient, let's call them, perceives that the other person is going to go away or has abandoned them, or maybe is just stopped responding to their text, they're going to have a really powerful reaction to that, because that's how they adapted to their earlier environment with that inconsistent caregiver. Like, it's just kind of cause and effect there. And it's difficult because you might see that and you think, oh, this person is overreacting, or they're really emotional, or whatever. And you have a lot of quite pejorative attitudes to that kind of behavior. But try to understand how it happens and how it is a necessary adaptation to the environment in early life. Another thing is unstable sense of self, and it's in the kind of crucible of the attachment relationship, constantly seeing yourself and your own feelings and your own thoughts reflected in the mother and having them fed back to you in a more sensible fashion. That's kind of how we develop our sense of self, as I said. And so if that's gone wrong, unstable sense of self. Very, very low self-worth is quite common, because, you know, it's hard to be happy if you're having these problems, I suppose, on some levels. Impulsivity is a big one. And that sort of makes sense, I guess. You know, if you're developing in an environment that's somewhat hostile and difficult to survive in, being impulsive, just doing what you have to do to survive in that moment, is a useful adaptation. But, you know, in adult life, it can cause problems. So a common problem in this group is substance use, which, you know, anyone can fall into addiction, but if you have sort of impulsive traits, which are not chosen in any way, they're just the way your brain had to adapt to its environment. If you have those impulsive traits, you're more likely to fall into that, and it's going to be much harder to remain abstinent. And also risky sexual behavior sometimes, I mean, not super often. I wouldn't pin too much on that. It's really the substance abuse, and definitely self-harm is very common in this group. I'm saying, so if you have 100 patients with emotionally unstable personality disorder, a majority of them will engage in self-harm of various sorts, and it'll be suicidal and non-suicidal. But if you take 100 people who engage in non-suicidal self-harm, still only quite a small proportion of those will have emotionally unstable personality disorder. So make sure you get the kind of numbers right in your head, that if you see someone who in your clinic who is harming themselves, is cutting themselves, or has a tendency, you don't start thinking emotionally unstable personality disorder straight away. That's, yeah, so be clear in your mind about that. Problems in, I guess, the problems that began in the earliest relationships kind of ricochet and continue, and clearly this pattern of feeling really attached to people, and then if you perceive that they're abandoning you, then getting really distressed about it and kind of throwing them off, causes unstable relationships. Low mood is often described in this group as chronic feelings of emptiness, and I don't really have a nice pithy explanation for exactly why that is. Maybe you can think of it partly as that attachment relationship, that constant, I'm distressed, mother knows you're distressed and names the distress and recognize it all. There's a sense that you gradually end up, you make sense and you can feel sadness and know what it is. And perhaps in someone where that hasn't happened quite so well, it's more like there's an emptiness, the emotions aren't there properly, or there's, I don't know. That's a very vague kind of answer piecing together from what we know, but I'm sure there are better explanations out there as to exactly why this is observed in this group. Parapsychotic experiences, which I can talk about probably more next week. This is hearing a voice in your head. I kind of leave that there, but just in short, a hallucination in psychosis, sort of hearing voices, wouldn't generally be described as a voice in your head. It would be described as a voice. The voice is coming from the TV, the voice is coming from the radio, the voice is coming from the fire extinguisher, whatever. But it's not in my head. No, it's a real voice. That's how it feels to the person. Whereas you get this interesting phenomenon, particularly in EPD, where they experience in a voice and it's not them and it's not their thoughts, but also they recognize that it's not actually someone physically talking to them. So there's a level of insight. It's an interesting one. I'm happy to answer more questions about it later. And disorders of the sick role. And this is why, I guess, or a big part of the reason why these patients overrepresent in healthcare, because they have dysfunctional ways of meeting their basic psychological needs. And sometimes they can involve, you know, if you're sick, you get looked after by people. That's what happens. That's how society works. And it's a good thing. But if you kind of have a real need, a real hunger, I guess, to be looked after because you weren't looked after well enough to start with in your life, and you still that desperate need of the child where their mother was sometimes there and sometimes not. I need to be looked after, because every child needs to be looked after, but a child that kind of needs it even more urgently because it's sometimes not there, remains. And you end up with, I guess, sometimes people fall into the sick role and really inhabit it, and it causes all sorts of problems. And it's really about kind of meeting an emotional need rather than just being looked after for whatever particular illness you have. So it's a tricky one. And I think as doctors, we can be quite pejorative about this. People who are wasting our time, whatever, they're not really sick. Well, it's a failure to recognize what the real need is there. And hopefully this is all reflected quite well in the case that we talked about. You know, when we've made sense, I guess, of EUPD in terms of these diagnostic criteria. And then I'll leave this a little teaser for next time, splitting and projection, which are very commonly observed in this disorder. If you want to have a think about what they even mean between now and Wednesday, please do, and I will explain a bit. It's very interesting and quite difficult to get your head around, but hopefully worth it. And that is it for this evening. So in the last minute or so, I'll just answer a question, and please drop questions on the chat. I'm happy to stay here and answer questions for as long as you like. So first question, would you say that separation anxiety in toddlers is a type of attachment problem, and can it be early signs of personality disorder? No. I can see why you'd think that, definitely. Separation anxiety is a normal feature, because actually I said about attachment behaviors being turned up to max volume. it's normal for the attachment behaviors to be set somewhere in the middle. Like, and actually it's very, very appropriate as a child if your mother goes out of the room to be distressed and to need them back, but not kind of completely overwhelmingly world-endingly distressed and able to be consoled. The mother comes back and comforts them and the kid's okay. But yeah, so good question. Oh, and I'll flick in the talk to the feedback slide. If I'd be very grateful if you can start filling that in as I answer questions. If one parent is very absent emotionally, but one is present emotionally, can this still increase the risk of developing a personality disorder? Very good question. So, as I said, you need to have a good enough attachment figure. If you have someone who is consistently there and responsive to your needs as an infant, that is enough to prevent you from developing personality disorder. It's not a categorical thing, though. It's not like either you develop personality disorder or you don't. That's not a useful way to think about it. So if there's some disruptions in attachment, particularly maybe if one caregiver is very absent or even sometimes is frightening, and that can cause all sorts of difficulties, you might develop some problems as a result, and those may eventually in adulthood be present in sort of a few traits that may cause some problems or may not. But if you have a good enough attachment figure who's there, at least one, that can be enough to develop sort of normal attachment patterns. And equally, actually, you can learn, so secure attachment is what we call sort of normal attachment, where basically you feel secure in the knowledge that your caregiver is going to be there. You can, if you even haven't had that in maybe the early years of your life, or perhaps someone who's come from an abusive household and has then been adopted, you can learn secure attachment. So it's not a life sentence, absolutely not. And even actually, to a slightly lesser extent than if you're adopted at a young age, but still to a degree, you can learn that in adulthood. If you have a really stable relationship, perhaps with a partner, you can kind of relearn some of those things that weren't learned quite properly in infancy. So we'll talk about that a bit more when we come to talk about treatment of personality disorders. Great. Right. Hopefully you all have the attachment link. I'm just going to actually whiz back to the previous slide and just quickly sum up what we've said, and then I'll clock off for tonight and I'll see you on Wednesday. Firstly, remember, this is a difficult topic, and it probably won't feel very easy, and that's okay. And there are all sorts of interesting controversies, which hopefully we can discuss a little bit more at the end of next week's time. But the best way to understand it is this young brain has adapted to the environment it was in. And that environment kind of was the problem. And as a result, you have traits of thinking, of behaving that then cause problems in later life. You get into a bit of a recursive cycle, though, because then you can say, oh, well, it's the parent's fault, right? But attachment patterns are heritable, not, well, I mean, a bit genetically, but also if someone is not able to respond effectively to their infant, it's likely that that's because they were not responded to effectively as an infant, and it goes back and back and back, and it's no one's fault at the end of the day. And that's quite important to bear in mind, because no one is to blame for this. It's a thing that happens. But yeah, the result is these maladaptive, so kind of unhelpful, disordered, if you like, and inflexible patterns of relating to others and yourself. Yeah, and EUPD is a big one. Right, lovely. Yeah, if you haven't done already, please. Oh, one more question. Do I have any book recommendations about human behavior and neuroscience? Good question. I mean, I have a bunch of textbooks about psychiatry. I don't know, the Oxford textbook for psychiatry just has loads of stuff in it. I'm trying to think of specific ones. What I would recommend, yes, actually, I have a really good book recommendation. If you read anything by Mr. van der Kolk, who actually produced the study of the graph with the different types of abuse, a particularly good one is The Body Keeps the Score. It's all about kind of a lot of what we talked about already, the impact of developmental trauma on neurology and on, to be honest, the whole body. So The Body Keeps the Score, very, very highly recommended book, which is good. Hopefully that's roughly what you're asking for. I'll have a think if I think of any other good books before next week. Right, I think that is everything. So cheerio, everybody. I will see you on Wednesday.